Dr. Pearlz Clinical Rounds here with the clinical case. Let's get right into it. 6-year-old male presents with a complaint of dysuria, urinary frequency, and urgency for the past 3 days. Patient reports worsening symptoms and describes the dysuria as being moderate. Patient has tried increasing water intake without relief. Patient has tried taking ibuprofen without relief. Patient denies prior history of STDs and reports being in a monogamous heterosexual relationship without condom use. Patient also denies prior history of a UTI. Patient denies abdominal pain, fever, chills, nausea, vomiting, flank pain, pelvic or perineal pain, testicular pain, and penile discharge. Remember to gather a thorough sexual history as it may help guide testing. Patient has hypertension, hyperlipidemia, and takes amlodipine and atorvastatin. Patient has no known drug allergies. Patient reports drinking 1 glass of wine every night. Vital signs are normal. An exam is negative for CVA tenderness and abdominal tenderness. Remember to assess for fever, abdominal pain, and CVA tenderness when symptoms are suspicious for a UTI. What diagnostic testing is indicated? A urinalysis and urine culture should be performed. The urinalysis can suggest pyuria when leukocyte esterase is positive. A urine culture can confirm bacteriuria, and susceptibility testing can help tailor the antibiotic regimen. The dipstick urinalysis is positive for 70 leukocyte esterase, nitrites, and 200 blood. Leukocyte esterase is an enzyme produced by white blood cells and is suggestive of pyuria. Nitrites are produced when gram-negative bacteria convert nitrate to nitrites. Lab results should always be used in conjunction with the patient's clinical presentation to support a clinical diagnosis of a UTI. For example, asymptomatic bacteriuria does not require treatment unless the patient is undergoing urologic intervention, is a recent renal transplant recipient, or is pregnant in females. Based on the patient's symptom of dysuria, what is your differential diagnosis? Differential diagnosis for dysuria in men should include cystitis, pyelonephritis, urethritis due to gonorrhea, chlamydia, mycoplasma, trichomonas, herpes, or epididymitis, orchitis, balanitis, prostatitis, or urethral stricture. What is your final diagnosis based on the symptoms and laboratory results? The final diagnosis is an acute simple cystitis. What is a clinical presentation for an acute simple cystitis? Symptoms include dysuria, urinary frequency or urgency, and/or suprapubic pain. Hematuria and cloudy urine may also be present. Systemic symptoms such as fever, chills, nausea, vomiting, malaise, pelvic or perineal pain are suggestive of a complicated UTI. Pelvic or perineal pain, along with fever, chills, and dysuria, can suggest prostatitis. Acute simple cystitis is not common in 15 to 50-year-old males. It is more common in older men, but risk factors such as having BPH, engaging in insertive anal intercourse, and being uncircumcised may increase one's risk. Older age, greater than the age of 50, chronic indwelling catheters, fecal or urinary incontinence, recent urinary tract procedures, or underlying urinary tract abnormalities may also increase one's risk. What bacterial organisms cause UTI? Gram-negative bacteria from the gut flora typically cause UTI in men and women. E.coli is the most common bacteria. Other bacteria such as Klebsiella, Proteus, Staphylococcus are known to cause UTIs. If available, reference the local community antibiogram. It is recommended to avoid using TMPSMX if the local community resistance exceeds 20%. In this table, we see a community resistance rate of 35% for TMPSMX for E. coli. When previous urine cultures are not available or there is no concern for multi-drug resistance, empiric treatment should be targeted towards gram-negative bacteria, keeping in mind that E. coli is the most common cause. What is the treatment for an acute simple cystitis in men? Nitrofurantoin, or TMPSMX for 7 days, fosfomycin as a one-time dose are considered first-line based on the same recommendations for acute uncomplicated UTI in females. Avoid TMPS-MX if the patient is on an ACE inhibitor or an ARB due to hyperkalemia, which may cause sudden death in older patients. Avoid nitrofurantoin, fosfomycin, and beta-lactams if treating for prostatitis. Avoid nitrofurantoin and fosfomycin if treating for pyelonephritis. You should also avoid nitrofurantoin if the creatinine clearance is less than 30, and use with caution if the creatinine clearance is less than 60. Just as in women with uncomplicated UTIs, beta-lactam antibiotics may be used. There is, however, concern for increased resistance with beta-lactams and is not the recommended first-line treatment. Fluoroquinolones such as ciprofloxacin or levofloxacin can be used, but with caution, as there are concerns for potential adverse effects. Side effects such as tendinitis, aortic aneurysm or dissection, QT prolongation, peripheral neuropathy, or the lowering of a seizure threshold may occur. Historically, a 14-day treatment duration was recommended for the treatment of UTI in men in the absence of fever. A randomized treatment trial of 272 patients comparing a 7-day course of Cipro or TMPS-MX versus a 14-day course proved to be non-inferior. Follow-up. Remember to follow up on urine culture and susceptibility results and adjust the antibiotic regimen if necessary. If the symptoms are worsening, make sure to reevaluate for sepsis, prostatitis, or complicated UTI such as pyelonephritis, and if indicated, transfer for evaluation in the inpatient setting. If the symptoms persist without improvement but the patient is stable, refer to urology for further evaluation. If there was hematuria on the UA, repeat the UA in several weeks to rule out persistent hematuria. That's it for today. Thank you for watching Dr. Pearlz Clinical Rounds. Don't forget to hit the like and subscribe button if you enjoyed the video. Let's move on to the next case.